and nursing ethics. Should promote palliative and end-of-life care for older adults and people with chronic progressive diseases through various international and policies research, health promotions, and knowledge transfer projects. She will talk on the topics quality of end-of-life care in long-term care, what and how to measure. Professor Chen, please.
Thank you, Patrick, for the introductions. And also thank you to Hong Kong Association of Gerontology for having me to introduce how we can measure quality of end-of-life care in long-term care. Actually, this topic is very challenging and very big. And so let's see how it goes in Hong Kong. So actually, this project has a very strong team, and then without their help, it is very difficult for us to promote the end-of-life care in long-term care, because this is actually a new area in Hong Kong, and I think this is also applied to Asia regions. Let us first take a look of the end-of-life care practice in Hong Kong now. So in this graph, you can see that the top leading cause of death in Hong Kong actually dominated by chronic progressive disease. For example, you can see heart failures, cardiovascular disease, even dementia is one of the leading cause of death. So we can see that for all these diseases, the death trajectory is expected. So we expect the patients with these diseases have a long journey with the disease already. And then how it goes when they come to the end of life. This is the graph showing the healthcare utilization in the last phase of life. You can see that among the last years of life, the use of public healthcare service increased dramatically, especially for the last few months of life. So you can see this not only increased the burden to the healthcare services, but we can also expect that the care would be very medical oriented, only focusing on the physical illness. So the patients may not be able to enjoy the last phase of life, especially with their family members. So that's why in the Quality of Death Index published in 2015 by the Economic Intelligence Units, the Hong Kong end-of-life care is being ranked quite low at the 22nd place out of 80 regions. And also we can see that for most of the deaths in Hong Kong, more than 2/3 of them age 65 or above. So the question is that what we expected for our last phase of life, especially for those in the advanced age? Have they ever tried to participate in their end-of-life care planning? What would be their preference for the end-of-life care? All this has not been tackled actually in our conventional care. So that's why we are hoping to improve the end-of-life care by including their voices and also the family members in the whole care planning. So in here we can see that there is similarity between the geriatrics and palliative care. Both of them highlight comprehensive care, holistic care. So in here you can see for geriatrics, we focus not only on physical illness, but also psychosocial needs and spiritual care. And these also apply in palliative care. And also if you are familiar with the principle of palliative care, you know that we introduce this philosophy at an earlier stage. That means there is a possibility for us to integrate palliative care and geriatric care together so that the person can benefit from the symptom control, from the psychosocial support, and also for the family members, they can have the support for anticipated grief. Because for older people, actually, they usually have living with the frailty and comorbidities with complex care needs. So the question for us is how to optimize the quality of care at the end of life care. But this is not without challenge, because both geriatrics and palliative care are specialties. How we can integrate two specialties together, we see the similarity, but they also have differences. So this is a big challenge, not only for Hong Kong, but the whole society, globally, actually. How we can measure good end-of-life care in long-term care. So here, when we look up into the literatures, there are lots of publications about the quality in long-term care, for example, from Australia, Canada, England, Finland, the Netherlands, and even US. So EU has already published a report on how to improve the quality in the long-term care. These include care effectiveness, person-centered care, care coordinations, staffing, management, and safety living environment. But when we look into these reports, we can hardly find the hints on how to improve end-of-life care, although we see that person-centered care can also apply into end-of-life care. But there is no specific guideline on how to improve or provide end-of-life care in these care settings. Especially we know that the resources and the infrastructure in long-term care can be very different from those in the hospital settings. Okay, so that's why we are very grateful to have the funding from Jockey Cup charity funds. So we are able to provide end-of-life care in long-term care settings. But first of all, we try to identify what would be the key domains and the key indicators for us to evaluate and also monitor the qualities of these end-of-life care service in long-term care. These would be very helpful for us to guide the institution on developing and also improving the service performance. So we expect that will be a multidimensional domain, and then there will be a lot of different care outcomes. So initially, we identify 3 aspects. The first one is environment. So if you have heard about our projects, you should be familiar that from these projects, those care homes who has already participated in, they are able to renovate their care homes and then have a single room for people joining this project, especially at the end of life. And then we also try to build up the task force working in the long-term care settings, and also how to guiding them how to provide the care. But still, there is no global consensus on how to improve the quality of end-of-life care so far. So in these projects, mainly it is on capacity buildings. There are a series of courses provided to the staff working in the long-term care settings, including how we introduce not only the geriatrics concept, but also palliative care. And then after that, we also focus on the palliative care principles, for example, the symptom management, psychosocial support, spiritual care. And then we also try to see how we can improve the caregiver support, even though they are not living together. But it doesn't mean that they do not have psychosocial concerns and worries about the health of the older people living in the residential care homes. And also, more importantly and challenging is how to provide care for the dying patient, because usually, in conventional care, it is not their duties. So it would be a challenge for them to provide care for residents living in the long-term care, and then they go through the dying process. And definitely, we also include grief and bereavement as a key component in the training. And then the team also have on-site support for the staff when they are going to provide these kind of care. So let us see how we evaluate the service. The quality indicators we identify are coming from literature review, but also from expert opinions. Here is an overview of the quality indicators we identify in the literatures and also from the expert panel review. This is dated back to around 3 years ago when we first developed these benchmarking tools. So the first part is about 16 statements concerning palliative care. It includes policy and guidelines, staff education, assessment, symptom management. And then the second component is on end-of-life care, and the third part is about bereavements. And then the ranking, there are 4 rankings from no relevant system on that area to it is established and also implemented. So perhaps at the very beginning, we think that because we have never provided end-of-life care in the long-term care settings in Hong Kong, they may be performed quite poorly, but this is not the picture actually. Let's take a look of their performance. So at the very beginning, that is the bar chart you can see here at the baseline before we implement the projects. Actually, the care homes, we could 36 care homes join in the project 3 years ago. And then At that time, they already performed quite well in most of the items, but you can see there is a room for improvement for some of the area. I will go through these indicators with you later on. But after 1 year, there is great improvement in most of the care homes. You can see that they passed the, if we set the 15% as the passing marks, most of them has already passed the marks for the indicators. And then 1 more years later, they have further improved in fulfilling all the quality indicators. So first of all, let us take a look of how they have well performed in that area. For example, those are mainly on the physical aspect. For example, in nutrition and hydration care, and then providing the information for the family members on symptom control, nutritional screening. These are already provided in the conventional care. So they are quite confident in providing these care. Actually, these not only for geriatrics, but also meet the criteria for palliative care. Okay? But the second part is how they have improved in over the first years. So these are more specific on the end-of-life care. For example, they try to do the comprehensive assessment and also discuss about the advanced care planning, that is the care preference for end-of-life care. They try to record it into the medical records and care home record, and then review all these preferences regularly. So these are very specific on palliative care, and then you see the care homes can be able to improve these areas within 1 year. But still, there are 2 items that need further improvement. If you remember the bar chart, there are some items still below the passing marks. So these are about how to handle the body of the deceased residents and also the post-death care. As I mentioned, this is a new area for the residential care home to provide this kind of care in their care settings. So perhaps it's not only about the resources or the manpower issues or their training, but also about the whole policy in Hong Kong and the legal barriers, how they can improve the post-death care. So we can see that this is not only rely on the care homes, even though they are very passionate and committed to do so. And after all these 3 years experience, we also try to improve the benchmarking to, now we have the version 2.0. So we have further restructured the statement. And now this is divided into structure of care, process of care, and outcome of care. And hopefully in the years, coming years, we are able to share with you all these performance for the new benchmarking. And naturally, because we see that the care homes has already performed very well in the first 3 years, so in the new versions, we have added some more items. So eventually for this new version, we have 60 items, and then it will be more challenging for the care home perhaps. So let us see how it goes later on. And then on the second part, we also have a staff preparedness on how to prepare the staff members. Although we see that we have already provided a lot of training, how ready are them to be providing the end-of-life care? So for this one, we have developed an instrument focusing on their willingness, whether the staff are willing to provide care for those dying residents, their competency, their knowledge and skills, and also resilience, whether they can care on or cope with all these stressful and emotional draining situations. So again, let us take a look of the 3-year patterns. So at the first beginning, we can see that the marks is from 1 to 5. So generally, they have improvement over these 3 years on all 3 aspects. The blue line represents the professional staff, and the green line represents the health frontline staff, including personal care workers and also health workers. And then although we see a significant difference between the professional staff and frontline staff, on the other hand, we are very happy to see that at the G2, that means 3 years after the projects, for the frontline staff, their performance is better than those of the professional staff at the first year. So you can see that the whole standard of quality has already improved over these past 3 years. And then we also try to perform a structural equational modeling, structural equation model. And then you can see that the resilience in the first year, the capacity and the willingness in the first year actually related to the second year and the third year. This is understandable. But we are also very happy to see that the capability, that means that knowledge and skills also may influence their willingness to provide end-of-life care in the coming year. This is very consistent in this 2 years data. And then in the second year, their knowledge and skills even can improve their coping. That means they are more confident to provide this kind of care in the care settings. So we see that capacity building, especially on improving their knowledge and the skills, is very important on how to promote the whole culture on providing end-of-life care. So capability, that means the knowledge and skills training is significant in the whole capacity building projects, and then it also affects their coping. Lastly, I would like to use a case to illustrate to you what all this means, what is meant by providing end-of-life care. Especially, we try to pick a case happen just during the COVID-19, how the end-of-life care in care home can support the family members better and also the residents better. So for this case, Ms. L actually is already in an advanced age, 86 years old, living in the residential care home. She has congestive heart failure, dementias, and also severe chronic obstructive pulmonary disease, COPD. She was already bedbound when she joined in the projects and highly dependent. And she was very frail, and then over the past 3 months, she has already admitted to the hospital for twice. And then each episode, she stayed in the hospital for more than 30 days. In August 2020, so everyone of us know that because of the pandemic, and then even she was being admitted into the hospital, the family cannot visit her. And then due to the poor general conditions, and then the saturations, she was being admitted into the hospital again, and she received antibiotics. And the medical team now is trying to consider whether nasogastric tube feeding would be provided to her because of her poor appetite. The family members actually were very anxious and worried about her conditions because they cannot visit their mothers. And her daughter was very committed. When she stayed in the residential care home, she visited her every day. And then, so the issue is how to come up with the care decision, whether to provide NG tube. So with the support of these projects, the family members is able to discuss about the end-of-life care for their mothers. And then finally, after the whole family conferences, they opt for comfort care and then decided to let their mother come back to the residential care home as the last place of care. And then the link nurse of the project communicate their decisions with the hospitals. And then finally, the NG tube is being withheld, and then Ms. L is being discharged back to care home. So what happened after she was being discharged back to the care homes? In the following 2 weeks, actually her condition further deteriorated over the 2 weeks. She was being kept in a single room. This is a privilege, actually, for those who participate in these projects. And then even though we are having a pandemic at that time, the family members still can visit her and accompany her throughout the 2 weeks. They are very happy to see that Ms. L can respond to them by nodding and also smiling. And then the care home staff continue to provide personal care to maintain her hygiene and promote comfort. And then the visiting medical doctors of the projects and also the CGAT team of the hospital visit her regularly throughout these 2 weeks to monitor her medical conditions. Eventually, she died peacefully in the company of her family in the care homes. So we can see that without these projects, perhaps she would be kept in the hospital for the remaining time of her life. So we can see how the project can help to improve the continuity of care, and also, as I have mentioned, to provide a holistic care to her until the last day of life. So this is a picture of her in the after she joined the projects. So to conclude, this project actually provides a framework for measuring the quality of end-of-life care in long-term care settings. We see that the staff competence play a very important role, especially on their capacity, like the knowledge and skills, because these would affect their willingness and also the resilience to provide end-of-life care in the coming days. And then this project cultivates cultures for improving end-of-life care in long-term care settings and also facilitate dying in place. Although we admitted that there are still much room for improvement, but we also are very grateful that the government has already place attention on this area. In the coming days, they are now, after the public consultations, probably we will be able to address the legal barrier, and then there will be much more facilitators on this area. The way forward is on the sustainability. As I mentioned, we cannot just rely on one project or one funding. How the government will be able to take up this framework as a guidance for all the care homes in the regions, and also how we can provide a territory-wide capacity building for all staff working in the long-term care home would be our missions in the coming days. So the project cannot be success without the support from Jockey Club Charity Trust and also the project team. We have a very committed team, and so far in the 4th years now, we have already have 48 care home join into this project. So this is very successful in changing the cultures. And then again, this project cannot be success without a very committed team behind us. Thank you very much.